Welcome, everybody, to the Critical Care Obstetrics Podcast. It's a pretty special time right now. We're in Orlando, Florida at the 2025 Association of Women's Health and Obstetric and Neonatal Nurses, the AWON meeting, which is always an amazing time. We get to catch up with a lot of great friends, colleagues, network, and see all of you guys out there in the wild. So we love this meeting. We look forward to it every year. And I'm lucky enough to be here with my friend and colleague, Dr. Lexi Hill. Lexi's another maternal fetal medicine specialist. We share a lot of common interests. We also both live in Arizona.
We do.
And I look for every opportunity I can to collaborate with you because you're such an amazing clinician, a fun person to be around. You have such a great insight on so many things. But today, I kind of want to talk about your perspectives on telemedicine, telehealth, and especially in the rural health context.
Sure. And it's funny when people say rural health, I think everyone thinks of that so differently because we're in the space of pregnancy. So one great example is Naples, Florida. And we're in Orlando right now, so it's kind of fitting, I guess you could say. But people hear of certain cities, they're like, oh, that's an amazing city. They can't be underserved or considered rural, but you have to think of populations. And so some of the cities in which I work may not be considered to other people as being remote or kind of rural for us.
Or limited access.
Exactly.
Yeah, I mean,
exactly.
So let me tell our listeners a little bit about you and you can fill in some blanks.
Sure.
But you are a full-time maternal fetal medicine specialist, but you're licensed in what, 23, 24 states?
It's somewhere between 23 and 25, depending on which one's still pending at the moment. But yeah, right about half of the United States.
So you're full-time telemedicine, and you really fill an incredible gap, which is specialty obstetric care in many, many underserved areas. And like you say, some are what people would consider to be big cities, but they maybe don't have a maternal fetal medicine specialist, or they may, people don't think about this either, but many maternal fetal medicine specialists are really only interested in prenatal diagnosis and ultrasound and may not have that comfort level with maternal care. So tell us what that looks like for you when you're caring for these patients.
Yeah, so when I see them and when I explain to people what I do and what you do and what we all do as maternal fetal medicine specialists is, it is called maternal fetal for a reason. And although it is one specialty, some people do more the fetal part and some do more the maternal. So most of my day is actually doing both. So when I do a consult, I say, hi, I'm Dr. Lexi Hill. I'm seeing you today for, and I fill in the blank. We're going to go through your risks as a mom during this pregnancy, and we're also going to go through how the baby looks on the ultrasound today and any risks there could be posed to the fetus. So I explain what I do, the title of maternal fetal, because it's confusing, right? They see an OB, they're like, oh, you're my other OB provider. And it's like, no, I'm kind of an extra layer. So I explain that and identify it so there's some clarity at first, because there's so much confusion in the world of higher risk OB patients. And what it kind of looks like too, as you mentioned, because of these little areas, which we kind of like to call maternal healthcare deserts, if you will, right? These places that are between bigger cities. So I'm originally from Texas, and you're originally from Texas. So we have a lot of similarities, Stephanie and I do. And when you think about it, you think of maybe San Antonio, Austin, Dallas, and Houston, the big cities. Texas is a really big state. And I grew up in a really, really small town population, originally 1,200 or less. So our biggest city, which was about 45 minutes away, was population maybe 80,000. They still don't have, to this day, a high-risk pregnancy physician in that city, even one that really, truly does work there regularly. And those are my hometowns, right? So to get care in person, one would have to drive, and this is just an example in Texas, right? One would have to drive maybe 3 hours from some cities, and even some maybe 5 hours.
People don't realize how big these distances are. Like, to drive from El Paso to Dallas is a day. It's a 12-hour drive from Dallas to El Paso. And so trying to cover all of that ground and provide care to all these patients, and that's just one state.
That's just one state, yeah. And people, I think, don't realize, too, how few MFMs there are in the United States.
Yeah, there's only, more are retiring. The last statistic I heard, more are retiring than are actually being trained every year. There's only probably less than 150 of physicians in our specialty that are being trained on average every year, and under that number take the board exam every year. So it's not like there's thousands every year coming out of training to be a subspecialist. So we have to be wise in how we utilize the resource of a maternal fetal medicine physician, because we're absolutely essential for many, many complicated patients, but we're not always available. I will say, from my perspective, COVID didn't bring a lot of good things, and it brought a lot of chaos and a lot of badness. But one thing it did bring was an open-mindedness to remote medical care. Because prior to COVID, it was absolutely unheard of and considered, I mean, it's an uphill battle to try and figure out a way to see someone remotely. We were doing it, but it was so challenging. It was difficult to do logistically. It was almost impossible to get reimbursed for. And just having the technology available on both ends. So COVID really opened up the patient acceptance of that type of care, physician acceptance, reimbursement for the type of care. And I think it's a huge opportunity.
Yeah, and I think that if you go back 5 to 10 years in the midst of that time of COVID too, people really felt uncertain about telemedicine and telehealth in general. And they almost sometimes had this concern they weren't receiving as good of care maybe because it was so new. And I actually was doing telemedicine before COVID happened. So there was telemedicine out there prior to that.
Absolutely.
And now I believe people are becoming more comfortable with it, which is great. And they're realizing I can get just as good of care, if not even better care, by not having to drive to all these places. And I don't think people realize how frequently, if you have certain types of high-risk pregnancies, how frequently you need to possibly have ultrasounds or see a provider.
Yes.
And there really is no need to have to drive an hour or even 5 minutes or 10 minutes to say, yep, my blood pressures look good today. I could have done that over telemedicine within, a couple of minutes, and you'd stay at your home the whole time.
Those diabetes visits, reviewing blood sugars and making insulin adjustments. I feel bad having her come into the office. I'd rather do it telemed over the phone or whatever. They get an opportunity to ask questions. Their kids are with them. That's a whole nother stress that impacts access.
Yeah.
So in your day, like you're in Arizona seeing patients, and your patients are, I know you see a lot of patients in Florida and 23 other states, but so tell everybody what that looks like. They're getting an ultrasound there, and then you're talking with them. How's that work?
Yeah, it's interesting. Although maternal fetal medicine is a very tiny little niche in the world of medicine, even within maternal fetal medicine, everyone does things differently. So across the U.S., it varies. So some OBGYNs in the smaller towns, they've had no MFM for the longest time. So they are doing a lot of their own higher risk obstetrical care. So they may just want the MFM in that area to do the ultrasound and not do a consult because they're like, no, I manage all my diabetes. Or they send their diabetic patients to maybe an endocrinologist, and so they just need us to do the ultrasounds. So it's kind of interesting. I tailor it to what that area of the United States kind of is doing, and also what insurance is covering within their practice, within their state. And then patient specific too, right? Because it varies.
Yeah.
So for that part, it depends. So sometimes it's mainly the ultrasounds. Most of the time it's the ultrasound on top of managing the diabetes for the moms and kind of going through all the maternal care as well. The next layer comes into the communities that really don't have any of the resources. So because we are such a tight-knit community,
we meaning maternal fetal medicine specialists. Yes, we all know each other. It seems like
we do, and it's a beautiful thing. And then over the years, when I'm in whatever state I'm in, it's so interesting. I'll be like, okay, this patient is going to need to see a fetal surgeon, like someone who is even more specialized. Or this mom has a cardiac condition, and I really need her to deliver at a higher level of care institution, but that may be 2 hours away. Well, thankfully, if I don't have the phone number of an MFM that's in town there, I can text Stephanie or a friend and be like, hey, who's the MFM in this big city right now at this academic institution? And thankfully, we're all generally really nice people and want to help patients. And I help to coordinate that stuff too. So the layers of what I do are very different. So when I remember in fellowship and even in residency, there's some people that really love to operate. And there's some people that really love clinic. And I feel like more like the surgical part than the clinical part. I love clinic. And so
I think that's great though, because just like there are lawyers that litigate and are in the courtroom, and then there are lawyers that are never in a courtroom and only do, court contract reviews or whatever. Like in medicine, we have the ability to find what fits our niche, but or our preferences are where we're best suited. To your point you made just a minute ago, just last week, I got a call from a colleague in another state saying, hey, your patient was on vacation here. She's 17 weeks, unfortunately broke her bag of water. We've stabilized her. She's coming home. How do you want me to handle that transition of care?
Yeah.
And she had my phone number. So
Right.
we managed the situation together.
Right.
But that also, to me, highlights some of the gaps and the barriers that exist with the fact that we're having to rely on our physician-to-physician relationships to meet these patients' needs because there aren't a lot of resources in place locally.
Right.
So you're doing potentially, or you tell me, are you doing a lot of like work that's better served by like case managers and social workers and nurses and medical assistants? Like, how does that translate for you?
It varies again by wherever I'm working and what resources I have. And so I utilize anyone that's there and available, but if not, it's a lot of me going doctor to doctor. And it's amazing how many times I see a patient in one state and they're like, I'm moving, or I just came down from a different state. And I'm like, who was your MFN there? And I'm like, I know them. And so it's a lot of calling and getting that taken care of. And just,
Sounds exhausting.
It's exciting, but that kind of goes back to when people were like, you're just going to do clinic. Don't you want variety in your life? And I'm like, do you know how much variety there is within clinics? I mean, it's a lot of different things and a ton of different electronic medical records. And so I tell people I'm trying to prevent Alzheimer's, right?
How many electronic health records do you know how to use?
I would say all of them. I mean, there are some common ones, like Cerner, Epic, all that jazz, inpatient, outpatient, eClinical Works. I've got them all. So when they're like, you need to do a training, I'm like, bring it on.
You're like, I can do the training for you.
Yeah. But it's nice because I miss a little bit of the continuity because there's something of the muscle memory when you're in a certain EMR and the comfort. And I do enjoy that comfort. It makes me more efficient. So this was a challenge for my brain to be able to go in and out of different EMRs quickly and efficiently. But I found that way to do it. Mm-hmm. And that's nice.
I want to hear about let's just thinking of the high risk and critically ill patient. It's not unusual in my practice that I'll see somebody in the office and be like, yeah, it's time for you to go in the hospital. You're severely hypertensive. I'm concerned you have preeclampsia. That's one of the most common scenarios that I see. I'm not sure if this is superimposed preeclampsia, chronic hypertension, what it is, but we're going to send you over to triage. And even in a very big metroplex like the Phoenix metroplex area, picking the hospital where the patient is in network, where she is comfortable going, where they can meet the resources that she needs at that time for mom and baby, and her OB provider can deliver, is a logistical challenge. And that's just one community with endless resources compared to most communities, frankly. So give us an example of like what it looks like when you're serving a rural area or an underserved area and you've got to put her in the hospital.
Yeah. So thankfully, any of the places I'm in, when I go in, I always kind of ask the basic route of that. Insurance always becomes a pickle because I don't always have immediate access to what insurance they have. And so then if it's an emergency, they'll figure it out in the triage area. But that's where I kind of have the nursing staff there and the community within the hospital give me a list. So for every location I service, I've either got a list or a person I can contact immediately to say, it's a maternal need versus a fetal need, and what level of care do I feel like they need? And then they'll let me know, hey, the NICU level is this. They do or do not have these services inpatient. And then I talk to the patient, and I usually call the OB and let them know as well. And it's just it's a team effort.
Wouldn't it be nice? As you're talking, I'm thinking to myself, there should be a resource where we can go and just say, what resources does this hospital have that's certified in some way? Like, it's usually not hard to figure out the NICU level of care. Most facilities have it on their website, but gosh, to have a repository of here's the maternal level of care, here's the NICU level of care.
Stephanie, check this out. One job I worked in the past, I said that, and this was just one job, right? One job, one city with the Metroplex area. But we covered, let's say, for an even number, 10 hospitals. And I said, hey, since I'm going to be on call at all these hospitals, here's a spreadsheet. And I put exactly that. What is the NICU level? What surgical specialties are in-house? Do they have anesthesia? Do they have OB anesthesia? Do they have in-house OB or the OBs at home? Do they have in-house MFM? How low down is the gestational age at which they will deliver? I had this whole list. And I said, can y'all just get this information? And they were like, yeah, no. Why is it that hard? It should not be that hard.
No.
Because it should be information that providers should easily be able to access, and patients should be able to go onto a hospital website and be like, oh, their NICU only goes down to 34 weeks. Man, I have triplets. I may deliver prematurely. That's not going to be the hospital I go to. You know what I mean? Like there should be some ability for that to be
Shouldn't be
easier.
this hard.
Shouldn't be this hard.
No.
And you know, one of the things that was my goal 7 years ago to bridge this gap was my frustration in how providers had the ability to say things to patients and patients assumed providers knew certain things that they didn't know. So there got to be like this aggressive interaction sometimes I could see with other people, patient-wise, and then me as a patient. We've talked about with being a patient, it's frustrating. So to bridge that gap, and so one thing I do now, which took me a while to get figured out, is I offer consults, like private consults.
Now, you do a lot of patient-facing work, both obviously in clinic as a telemedicine physician, but also as a private physician that'll provide a lot of education. So tell us a little bit about that.
So it's all through my website to make it easy, but...
What's your website?
It's drlexihill.com. Pretty simple. Thank goodness. Thank goodness that domain name was available.
Can you imagine if somebody had taken that?
I know. Well, there was it was a little bit of a struggle, but thankfully all the social media things too are all the same. So that makes that nice and easy too, right? But the malpractice issue, like getting insurance, getting a license in multiple states, this took time to build up. But the people I think this is best for are the ones that are in those sticky situations. And these are friends of mine who inspired me to do this too, because they're like, I had a traumatic last delivery. I had a hemorrhage. I had preeclampsia and I don't know much about it. I've had a miscarriage and I don't know if I should start trying to get pregnant. So like if you had a complex postpartum issue or a prior birth trauma that you're just not sure how to proceed with the next one. Preconception consults are so difficult to get with a maternal fetal medicine specialist because they're booked. They're very hard to come by. So, and also a lot of maternal fetal medicine doctors do not like doing preconception consults.
You know, that's true. And I think they're time consuming. They're very labor intensive because there's a lot of issues. And frankly, they're not generally very uplifting because once a patient is pregnant, how you counsel them is a little different than you counsel them when they're considering a pregnancy because you almost have to be a little bit more, I don't know about blunt or what it is, but the risks sound riskier when you're not pregnant.
And I always say to people, you know, when we're thinking about getting pregnant again or for the first time, I'm going to tell you things that may sound scary. And my job is to tell you what all the risks are. And if I do have percents, which we have sometimes we don't, I can say low, moderate, or significant. And your job is to decide if you want to accept those risks. It doesn't mean these things are going to happen to you, but your risk could be slightly higher or significantly higher depending upon your history. And so it's this nice little balance, right, of figuring that out. And that's a space where people need to see a maternal fetal medicine specialist, but can't get in.
Yeah,
and,
so you are that gap. So there's other barriers too to getting access to a maternal fetal medicine specialist. They might not be available in your area. I find that some OBs are very reluctant to refer to maternal fetal medicine for whatever reason. They may not understand the value. They may think that they're filling that void, and they might be from their perspective, or they may not know what they don't know.
Right.
But anybody can access you.
Yeah, and
pregnant or preconception. Correct.
And you know, the biggest thing too is when I've had people find me, sometimes it was ironically through Google. One person needed.
That's a great thing.
I know.
Holy
I was
cow.
like, but I don't do any like paid ads and stuff. And I was like, yes, I'm on the Google now. You know,
I made it.
But this person, I mean, I do need to be licensed in the state in which you are at the time of the consultation. That's important. So
there's a good chance that there's a 50% chance of that.
50% chance. That's right. That's right. You know, and there was a person that found me and they went through Google, but they were going to proceed with IVF, and their reproductive endocrinologist could not get them into a maternal fetal medicine specialist in their area.
Wow.
And they said it will be 6 months until we can get you in through your insurance. And she was like, but I want to do the transfer next month. We're ready to do the transfer. She could not find an MFM. So she went online and she was very nervous. She was like, I don't really know you and your credentials. And she was like, but I read up on everything and you seem legit. I'm like, promise you I am. And I think that's the concern when you're doing telehealth, telemedicine, and you didn't get referred by a doctor that you know and trust, because now I'm a new person to you.
Yes.
And so I try, when I do my consults, I have like diplomas behind me because I think it calms people down to be like, oh, this is not someone just sitting in their basement, right?
You're not that good
consults.
at Canva, are you?
No, I need to get better at that. But this patient, when she reached out, she was like, thank you so much. And she was able to proceed with her transfer. She just, But she had to have this required clearance by an
couldn't
MFM,
get access.
but couldn't get access.
Listen, 6 months is a lifetime in an IVF patient's life. I mean, that's a long time to wait to get to start your cycles.
It's crazy. And I do cash pay because as a patient, I've had to do cash pay a lot because some doctors don't take my insurance. And given my cardiac conditions, if I'm with the same doctor and my insurance changes, I really don't want to have to find a new cardiologist.
Well, I think you're filling a gap that exists. There will be patients who just don't have that kind of access, which is really tragic that there's a group of people, a large group of people in the U.S. that the way current things stand, they just aren't going to have access. Right. You know what I want to hear more about? By the way, I love a preconception consult. Anybody who wants to talk about their rest before pregnancy, like, we are all about it because we forget about the mom. And in my opinion, we often forget about the mom, and it's so important. But I want to hear about, I'm just putting myself in your shoes and like a day in the life of Dr. Lexi, although I will never get up at crack of dawn 30 like you do. But I would say that admission to the hospital, like, can you think of scenarios or what are the challenges you face when you've got a patient who's in a rural setting and she doesn't want to do what you're saying? Because she doesn't want to leave her community and deliver her baby an hour and a half away or be hospitalized for an indefinite period of time an hour and a half away. What does that look like?
Yeah, that's hard. And here's the thing I always remember back to medical school when you have your white coat ceremony and you take your oath, right? Your Hippocratic oath. And I always remember...
First, do no harm.
First, do no harm. And patient autonomy is huge to me.
Huge.
And I always talk with patients, I'm like, your body, your choice. So I'm going to educate you the best I can. I'm going to make sure you understand what I'm educating you regarding and that you know your risks. And then we get into, let's talk about what you are choosing now that I've put this in front of you, because it is your choice. And so when
I always tell people, you're not in jail.
No,
you don't have to do what I'm telling you, but here's why I'm telling you what I am.
And so then it gets to, now I have to talk with my providers in that community to say, I've talked with your patient, they understand their risks, and here are the things that they've chosen. And then we have to figure out where we can safely get this person that if things do go south, from the risks that are there. Because a lot of times when you say to people, here are your risks, they're like, yes, I understand those, and I think things are going to go fine. So I don't want to go somewhere. I'm just going to roll the dice in a way and hope that things go fine. It's coordinating that, okay, if you're choosing not to go to these locations, I have to put a team together that will take care of you, understand that if and when things are going south, you have the route to get to that higher level of care easily and quickly.
Yeah, and this is going to become a bigger and bigger issue because as hopefully hospitals and facilities will start getting more and more leveling and start establishing you guys have heard us preach scope of service. Is this patient inside your scope of service? So let's take an example of a patient with a complex cardiac defect that requires specialty care, but she does not want to deliver at the specialty facility that is appropriate for her. And she shows up at her rural hospital where she is outside their scope of service. First of all, if you don't have a scope of service, you're not going to know if she's in or out. And the decision's often made by how far along she is in the pregnancy and not what mom's individual needs are. So for those of you at the facility and the receiving end, when that patient shows up, you need to have a plan in place for what happens. How are we going to handle that situation? And how are we going to get her where she needs to be? The patient always has to consent, and I think we have an obligation to try and remove as many barriers as possible to make it easy for them to get the care that they need. But this problem's only going to get worse because these hospitals are closing. The maternity care deserts are getting bigger and bigger and bigger. And if you haven't had this happen to you yet when you're in triage or on L&D, it's coming.
Yeah, and when you bring up the plan, it's kind of like whenever I was inpatient and we had someone who had ruptured membranes at that peri-viable or even pre-viable period. And I don't know if it was you and I that talked about this, but someone suggested to me at some point putting a sign on the door, the bathroom door, because it's seen there in the hospital. When we are at this gestational age, our plan is this, this, and this. When we're at this gestational age, our plan is this, this, and this regarding steroids, magnesium, et cetera, whatever that it may have been for that hospital. There's clarity. And I will say it again, and one day I will meet her. Brene Brown, I love you. Clear is kind, unclear is unkind. Clarity. So in a note, I do my best, and I know I'm not perfect at it, and none of us who are providers are. of having a note that's educational, but yet clear at the end. In this scenario, we will do this. So cardiac patient, if she is 24 weeks gestational age and shows up in preterm labor, she is to be transported. Or that's my recommendation. If she is 37 weeks and is stable this is the recommended plan. So what I call it is tree branching, right? Here's the scenario and what do we do? Here's the scenario and what do we do? So it's so clear. And so the patient understands that. And if I'm able, I give them a copy.
Yes.
It's so nice to leave the office with something. And people think, well, with telemedicine, I don't get any visual aids. Nay. Yes, you do. I have them like in binders all organized.
Why does this not surprise me, Dr. Lexi?
I know. It's like color-coded and everything. And I show it to them. And actually, like when I'm like, here's the dose of aspirin you should be taking, I'm like, just pull out your phone and take a picture. Because if they write it down, they're probably going to lose the piece of paper they wrote it upon. But if you take a picture, they're going to be looking through their phone later. Like, oh, I got to go get the aspirin that Lexi told So
and I have my medical assistant email them whatever education things they need after the telemed visit. They just get it emailed to them.
Yes. Here's the QR code, scan it, and then you can go get all the information I told you. And that's the other thing too, is that education for people in the room. What if it's just the person and not the person they live with, their significant other, their parent, their sibling, whatever? Then you say to them, and that's why I love what I'm able to do now. I'm like, I know I told you about Down syndrome today, and that your baby has an EIF. I know you're not going to remember all the terms. Go to the YouTube channel. There's an entire video with links underneath so that you guys can talk about it together and then come back with any questions.
Yeah, y'all should check out Dr. Lexi's YouTube. She does so much education on so many topics. I can't even go into them. There's so much there. But, it's funny, the notes, I'm the same way. I love lists at the bottom of my notes. It's like I'll write a detailed note with all the summaries and then with all the recommendations, and then every note ends with summary : ... And at a meeting a couple of months ago, an OB that I worked with in another community came up to me and she's like, oh my God, Dr. Martin, I was in a rural community. She told me I was in a rural community and you used to see my patients. You don't remember me because we haven't met, but I loved your notes. And I was like, what did I do with my notes? And she talked about this, like I could go to those bullets and know. So the detail is important. It's really, really, and to make it easy to find, it doesn't have to be buried in paragraphs.
No.
Another thing that I've found really helpful in trying to help patients understand risks, especially when it comes to like things that to us are crystal clear need to be done to minimize risk and improve pregnancy outcomes, but to the patient's really hard to wrap their mind around. First, if it's possible, don't force them to make any commitments or decisions. Just plant seeds and have repeat conversations. Be willing to hear their perspective and validate their perspective, even if you don't agree with it. You don't have to agree with it. They sometimes just want to feel heard. I'll give you an example. I had a patient recently who, she is very young, early 20s, and developed a clot in her heart. Still don't know the etiology. She had to have open heart surgery to remove this thrombus from her heart, and was on full dose blood thinners for quite a few months afterwards, and then stopped them and is now pregnant. Clearly, this patient needs to be and has been told she needs to be on lifelong blood thinners. We never found a reason. She's pregnant. Her risk of clotting is even higher. And she was very resistant to being on blood thinners during her pregnancy. And I think we had 3 visits where we just talked and I listened to her and I explained my perspective and the concerns that I had. And what it really came down to is that she kind of started crying one day and she said, I just feel like I'm too young to have this kind of a problem. And I just don't think I just don't want to be on blood thinners for the rest of my life. And I'm just too young for this. And I'm like, I get that. I hear you.
Yeah.
But I want you to be around for a long time for this baby you're about to have. And guess who's on blood thinners?
Yeah, there you go.
And then she came back and she's like, I'm relieved I made the decision and it's not that bad. But it took a time.
Yeah. And I like the question of, can you help me understand?
Yeah.
Right. So when I have someone who's not taking medicines, I get really frustrated when it's like patient refuses, patient non-compliant, and then not my note. And then I get a note and I'm like, can you help me understand why you won't, or you're not taking this blood pressure medication? And recently with someone, it was, no one told me how to take it. And I don't feel good when I take it. And here's the thing. I'm on a beta blocker for life. When we give people a Betalol like candy, we use it all the time, right?
Every day.
You know what? If you don't eat when you take a beta blocker and drink a lot of water, you're probably going to feel like you're going to pass out.
Especially if you live in a desert.
Especially when you live in the desert. And, we don't think about that. You're going to get a headache if you take nifedipine without a shit ton of water. Like, these are things that we just don't tell patients to do. Like, when you take folic acid, you should eat with that as well. Take it with certain foods. Same with iron. Like, there's different things that we just don't tell people because as providers, we don't really have the time often.
But that's where all your education tools are so helpful, because we can't say everything at every visit.
Can't. And that was the part where I was just like, I feel like I'm not, like, I want to help even more. However, I don't want the next patient to be so mad because I'm running even further behind. But the patient I'm with, I want to tell her a little bit more about, like, don't take your iron with coffee. Like, you know, don't take it with dairy, but I don't have the time for the extra stuff. So that's just the part where it's like listening and you know, it's always the patient's choice. However, being able to educate them a little bit more so that they know, because oftentimes the reason they're not doing things that were recommended is they may not understand the right way to do it, or they have a fear behind it that they haven't expressed to someone yet.
Right.
And that's that big part of, that's where we need to be able to have that time with them. I think it's so important.
I couldn't agree more.
Yeah.
But this has been amazing.
I know.
I want everybody to know where to find Dr. Lexi. So tell them all about where they can find you and follow you.
Website is just drlexihill.com. That one's pretty simple. At the very top toolbar, there are free downloads. There's all kinds of great stuff. I won't even go through it. One of my favorites is picking a prenatal vitamin. And there's 13 questions to ask your provider just to advocate. That website takes you to the YouTube. There's videos on what if my baby's breech, how to talk to your provider about an external cephalic version, linking you to spinning babies, all those fun things. My major was nutrition, so there's a bunch of stuff in there about nutrition. There's a whole course that you can find online there. There's actually a free code.
Tell them about the code. And we'll put the code in the show notes too.
But it's a health and nutrition course, and it takes you through preconception, first, second, and third trimester, organizes the videos, puts amazing links and downloads in there. And the code for that is just the word baby in all caps, BABY. And then for those of you who are really in a community and you're an MFM even, or you're a nurse, whomever you are that's in that community, I have these little courses on what I would say would be our 5 bread and butters as an MFM: advanced maternal age, IVF, hypothyroidism, diabetes, and hypertension.
It's 95% of what we see.
And I have full courses on that. The free code for that, pregnancy, all in caps. And you can do it as a provider. You can have your patients do it. Like, if you have new consults for any of those things, you probably got to spend maybe 5 minutes with the patient face-to-face, possibly, let's say. Send them home with that course. Then they will be able to really understand and ask the right questions. So when they come back, they can just communicate with the provider better. You know, that's the whole goal of all this.
It's amazing.
So
You're amazing. Thanks you so much for sharing your perspective. Thanks for listening, everybody. And we hope you like, share, and follow us. Go follow us on social media, and we'll be back for more soon.